think we will make a start. We've got a good number in, considering where we are and everything else that's going on around the world. So very, very grateful for people joining in. Some of you I sort of recognise, some names I don't. It's always good to see a few new ones. This is something we set up during COVID. And at that point, because things were so fast moving, we did these weekly. And as the pace has kind of naturally sort of steadied, we've kind of changed the frequency slightly. But we've been very lucky enough to bring some fantastic people together to record some presentations and Q&A sessions of about 12 to 15 minutes, usually themed. So please do encourage yourselves and colleagues to just go back and look through. There's nothing kind of out of date on there. There's some really good detailed technical discussions through the website. There's links to code and schemas and blogs and all that. So we're hoping to just build up a resource, and we're very grateful to have some speakers again this week to help keep going with that. We're going to cover a topic that we've run as a bit of a thread through some of our sessions, which is mental health, which we just all kind of, I think most people are kind of very personally interested in, particularly with everything that's going on at the moment. That's linked to cross-cutting themes that we've covered in the past, like you'll remember when there was a lot of coverage about domestic abuse during lockdown. That we did a really interesting session on that quite early on with the police, where we managed to sort of navigate the IG to link police data and health data together. But mental health is something that we feel like we want to keep coming back to. And we're also covering vaccine data again today, which we have covered before. But again, I think people on these calls are covering this at a much better pace than sometimes is being done centrally. So the group is here to agitate slightly as well, but to publish completely openly all of the sort of thinking that we're doing. So without further ado, we've got some great speakers. I'll get into it. I'll try and hold us to time. Paul and I will monitor the chat, try and keep the chat very busy. We will publish all of that as a resource. There's always some really good links to funding, offers of future presentations, new networks being created. So it's a really rich resource. Please do get in, and Paul and I will monitor it for questions anyway. We're going to cover mental health data first. So straight over to Kate and Paul, and share away. Thank you, Paul.
Can someone please let me know if they can see my screen?
I can, Paul. Looks great.
Great. So morning, everyone. Thanks for inviting me. Bit of a two-hander here. So I'll go first, talking about psychological therapies data. I'll hand over to Kate then to talk a bit more about the other mental health data that's available through NHS Digital. So just to introduce myself, I'm Paul Jennings. I'm an analytical section head within NHS Digital. And what that means is I'm responsible for the official statistics that go out around Iaf, which is our psychological therapies program in the NHS. So I'm just going to give you a bit of an overview about what that program is and some of the data that we hold in NHS Digital that supports it. So first, what is Iaf? So improving access to psychological therapies is an NHS program, and it's centered around talking therapies for mild to moderate anxiety and depression. Sometimes you'll hear talking therapies referred to as psychotherapy, and what it means in practice is working through the problems that I've listed with a trained therapist. There are many types of therapies that are available through the Iaf program, but frequently what you'll see is that these therapies are based around something called CBT, cognitive behavioral therapy. And it's kind of very basic level. What that means is it's a treatment that evolves around how our thoughts influences our feelings, influence our behavior, and trying to break that cycle really and improve people's mental health through that kind of mechanism. So in terms of how that treatment is delivered within the NHS, the patient will either be self-referred or they'll be referred by usually a GP, but they can come in to the service through any number of different routes. Once they're in the service, the service will do an initial screening to assess what the symptoms are and how they can be treated. An appropriate course of therapy will then be determined by the clinician, and this will result in a course of treatment being administered. And there's any number of things that can go into that course of treatment. So as I say, the core of it is CBT or other relevant therapies, but there's some additional kind of treatments that can be given around that. So patients can also have employment support either to get back in work if they're out of work, or if they're on long-term sickness, they can have some employment support to try and get them back into the workplace. Something that they're considering as well is treating physical symptoms alongside mental health symptoms within the same kind of care setting to give that idea of holistic care to the patient. Increasingly, what we're seeing is internet-enabled therapies. So this is where, for in particular mild kind of treatment, the patient will kind of engage with a web-based platform rather than face-to-face sessions. As a result of this treatment, the patient can either recover, or failing that, the clinician will step them up potentially to a more what they would call a high intensity treatment. I'm going to skip over how outcomes are monitored just because I'm short on time, but suffice to say that that the core of it is the patients complete questionnaires that kind of like self-assess how their symptoms are of anxiety or depression, and from these questions we can extrapolate whether the patient has measurably improved in their condition over the course of therapy. I'll also skim over this slide as well because I really am short on time here, but in terms of the data submission requirements for the system, the care activity takes place and it's then held on a local patient administration system within the service. This is submitted to NHS Digital on a monthly basis through what we call an intermediate database. There's an online platform through which the service providers can submit that data to NHS Digital. We can then feed back information to those services about how high quality their data is, giving them a bit of a feedback loop and an opportunity to improve that and really maximize the data quality potential. And then once we have the kind of finalized data from the services, we can then pull together a national data extract, as we call it, and build our official statistics publications and other insight on the back of that extract. In terms of the data that's collected, I'll just kind of finish on this. This is quite a daunting kind of relational data set diagram, but I'll just kind of walk you through it very briefly. What we have in the yellow boxes are patient information, so kind of their demographics, whether they're in employment, any social and personal circumstances that are relevant. We have information about the referral, so when it started, when it ended, and kind of relevant diagnoses. We have these green tables that talk about other kind of presenting complaints and any long-term physical health conditions. And the purple coloured tables relate to individual care contacts that take place. So this is where the patient questionnaire data will flow, from which we'll be able to determine whether an improvement's taking place or not. And any other pertinent information from the individual care contacts. And just to finish, because I know I'm a little bit over time now, but I just wanted to describe the official statistic measures we do. So I will post a link to the official statistics page on the NHS Digital website into the chat box, so look out for that. But in summary, we tend to publish 3 different types of measure within the Iaf publications, and these are patient outcomes, so whether patients improved or not, what the overall recovery rate is, both nationally and locally. We publish waiting times, so there's certain standards that the services are expected to adhere to around clearance rates, and we publish information about that. And we also publish information about kind of volumes of activity, how many referrals are coming in, how many are getting cleared, how many are recovering, and so on. So as I say, I'll put those links into the chat, but we do publish that information, huge range of information, in fact, on a monthly, quarterly, and an annual basis. So that's everything I wanted to cover. Very brief overview there. Hopefully you found it helpful, but I'll hand over to Kate now for more information on the mental health statistics we publish.
Really helpful, Paul. There's a few questions in the chat, and I'm always happy to cut Paul slightly short at the end. So we can come back on some of these as well. But have a look. There's a few things there for you.
Yeah, I'll try and address those in the chat as well as I go.
Thank you. Over to you, Kate.
Thanks, Paul. Can you confirm you can see my screen okay?
I can. Yeah, nice. Yeah. All good.
Yeah, great. Okay. So we've just published our annual mental health bulletin, which covers the year 2021. So I just want to share some of the findings from that, just to introduce what is a mental health services dataset. So similar to Iaf, it's a patient level dataset, record level. It's based on secondary uses data set, which covers children, young people and adults who are in contact with secondary mental health, learning disability and autism services. And they can either be located in England, or those individuals are located outside England, but they are have their activities being commissioned by an English CCG or an English specialised commissioner. We've got data from 2006-07, but the data set has changed over time. So this chart shows the number of people in contact with secondary mental health services. The dotted lines are where the data set changed. So initially the data set just covered adults. It changed then in 2011-12 for us to collect high security units. It changed again in 2014 when we included learning disabilities in the data, and then it changed again in 2016 to include children and young people. So that accounts for the increase in activity up to 2016. The scope of the data sets then being the same for the last 5.5, nearly 6 years now. So we've got a good time series of data. Some of the increase, though, in that time is due to lots of improvements we've done on data quality. So at the beginning of 2016, there was about 110 providers submitting data. We've now got more like 320 providers submitting data to the dataset every month. And that accounts for some of that increase in activity. It tends to be some of the more smaller and providers who've started submitting more recently, so it's not like a massive increase in activity. I want to go through a little bit about health inequalities because we're short of time. I won't go through. So looking at the data by age and gender. So this graph shows the proportion of people in contact with secondary mental health services in 2021. And overall, the majority of people are over 18, and there's more females overall. But there's two age groups where there's more boys than girls. So in the 0 to 5 and the 6 to 10 age groups, more boys are seen in those age groups. And you'll see that females really dominate some of the teenage years. So from aged 11 to sort of around 34, a lot more females are seen than males. But when you look at number of bed days, so these are actually about admissions, people admitted, there is a lot more male bed days in the data set, and the same for both. This 2 years worth of data. If you look at ethnicity, so this then is looking at people admitted by ethnicity. You can see there's a much higher proportion of people from Black or Black British being admitted. And then if you actually look at rates of restraint per 100,000 people, you can again see that Black or Black British are a lot more likely to be restrained. In fact, they're 5 times more likely to be restrained than white people, according to our data. We've also had a look at indices of multiple deprivations. That gives an indication of deprivation by area. Looking at the proportion of people admitted by indices of multiple deprivation, people who live in the most deprived areas are most likely to be admitted to hospital. And again, if you look at the restraint figures, people living in the most restrained areas are more likely, most deprived areas are more likely to be restrained. With there's 2,581 people who were restrained in the most deprived area in 2021 compared to 585 in the least deprived area. We've also got some stats by location. So this is goes back to proportion of people in contact with secondary mental health services who were admitted by CCG. You'll see proportions are higher, tend to be higher in the urban areas, but also in down here in the southeast coast as well, and around Yorkshire. Some of that might be according to people's age. So, and this is just a theory of ours, that ONS, so that older people are more likely to be living in areas of natural beauty, national parks and the coast. And then if we look at our data and the number of people in contact with memory services, we are getting higher proportions down here on the coast and some of the other coastal areas. How am I doing for time? A couple more? I'll carry on till I'm stopped. Just showing some stats from our Mental Health Act publication, which we put out for 2021 data in October. So this is showing detention rates per 100,000 population, and there's a higher rate of detention for Black background, so African and Caribbean. There's a really massive level here for around the category of any other Black background, and we believe that is because if when the data is submitted and if people aren't asked directly, we believe that the providers possibly guess and put people into the other Black background rather than the African or Caribbean. And again, it shows people in the most deprived areas are also more likely to be detained under the Mental Health Act than those in the least deprived areas. And then looking at the length of detentions then by gender and age and also by ethnicity, we find that the length of detentions are higher for those in Caribbean and white and Black Caribbean ethnicity groups than for any other groups. And just to highlight that we are making every year, we tend to make some changes to the data set. So we've just made a change from October data. We're changing how gender is collected, so we will be clearer about whether gender is different from gender determined at birth. And we're also collecting additional data about restricted interventions. And then I've just provided some links. If you're interested in what I've been speaking about, there's a longer presentation about that and one of our recent events from that second link. And then we also do a number of other events where we talk about the data set. Thank you.
Really interesting. Thanks both. And there's quite an active chat going on there. Thanks, Paul, for coming back on some of that. Is it too early to talk about research between, and I'm trying to be the perfect chair and link to the next topic, which is vaccine data, between what's happened over the last couple of years and mental health, and if particular groups have found that harder than the average? So the data about restraint and so on by IMD, by ethnicity and so on is sort of as we would expect, and I could show you data from an acute which looks not always similar but often similar. And if you break, I'm particularly interested in breaking ethnicity out into much more detail than what we've got there. So looking at, we've got a big traveller population in Kent, we've got a huge Nepalese population and Polish population and Sri Lankan, and trying to get to that level. Is there anything coming out yet about how groups have been more adversely affected than not? I'm conscious we've got lots of middle class people on here who can work at home, for example. They may be missing out on some of these mental health problems, or they may be getting different ones from becoming agoraphobic. Is there any research that you're starting to publish about the last couple of years?
So we've not done anything linking it to COVID. So we've been working jointly with OHID, who used to be PHE, looking at standard mortality rates. So, and that does do some breakdowns by ethnicity. We've only gone back to, we haven't got the data yet for the last year because we're reliant on the death registrations. We're doing it in a calendar year. But I know OHID are doing some further work looking at as well with rates with COVID. So I'm not quite sure when they're going to publish that, but I know we're working with them on that and to check their methodologies and things. So I expect there will be some work coming out around that.
Yeah, really interesting. Part of the sort of thrust of this group is trying to get stuff kind of quickly, something, and often things that are counterintuitive. So we got data yesterday across a few of our acute trusts, and a lot of the people in with COVID are people who've, there's a big unvaccinated population, which is kind of interesting to understand, and how that varies by different ethnic groups. But we've also got a sizable chunk of people with adverse reactions to vaccines as well, which we don't want to sort of wait a year to kind of find that out almost. Really, really helpful. You'll get loads of questions in the chat, Kate, so have a look in there as well.
Yeah.
We're going to move to Tom and Giles next, and I've tried to bridge us across to vaccine data, so over to you two.
Excellent. Really appreciate it, Mark. Superb chairing as ever. So I'll just do a really brief introduction. So this is a piece of work that well, the team at ODI Leeds, as we were then, now Open Innovations, did in July to visualize some COVID demographic data, COVID-related demographic data. But it sort of came as a request from the team at Magpie, who just happened to be along the corridor from us, where we are in Munro House, just through the door behind Paul Connell. So Tom, if you could, I would be really interested if you could do a little bit of context setting and just explain what it is you were doing, why you needed us to take a look at some of the data, and then I'll run through the tool we built.
Yeah, of course. Yeah, thank you, Giles. So, back in the early summer, sort of June, July time, Magpie was commissioned by Public Health England, as was now UK HSA, to run a campaign across Yorkshire and the Humber, with three objectives really. One is to increase levels of vaccination. Two, to increase levels of testing, and three, to improve levels of self-isolation behaviour. So Magpie is a behaviour change agency by trade, and the team tends to use something called a COM-B model, which I'm sure most people here, well, a lot of people here will be quite familiar with, but it looks at people's capabilities to do something, the opportunities they've got to do something, the motivations behind it, and what the behaviours are associated with it. So we were running research in July to look at, I guess, the vast amounts of kind of evidence that have been collected over the first kind of 12 to 18 months of the pandemic nationally. Then talking to colleagues right across the local system, so NHS, local authorities have been running COVID interventions for the last kind of 12 to 18 months, to find out what their experiences were and where they're finding it particularly difficult to either increase levels of vaccination, self-isolation or testing in some communities, and putting all that together. We found that there was a real need to actually create quite literally a picture of the region, to understand the trends behind vaccination rates right across the region. What we started to find, and I can go into this in a little bit more detail as we go on, was that there's certain pockets of groups, again, kind of IND related in terms of its geographical distribution. And what the ODI database data sets allowed us to do is to really identify where we needed to conduct more research to understand why things were the way they were. And so I can go into that a little bit later on. Yeah.
Well, so when you came to us, you'd been, in fact, I'll share my screen at this point. So I've got a few things, a few web pages to show. Hopefully that'll be the right one. I've disappeared now. There we go. So can everyone see the Public Health England local health dashboard? So this was the visualization that you came to us and said there's some really great data in here. But of course, and it's an amazingly good tool. You can drop all sorts of different backgrounds on and flip between different things. So it's a really great sort of data location tool set. But what it doesn't give you is the ability to compare between regions very simply. So we love hex maps for that kind of thing, because of the granularity of them, and the centre of York there, or the centre of Leeds, are really densely packed, and you have to zoom right in to be able to see anything. And of course, it hasn't got any COVID data, so vaccination data, case data, and the like. So kind of the the ask was, can you give us something where we can quickly do this analysis, rather than extracting data, mashing it together in Excel and coming up with our own visualizations. So what we did was first of all to download the data from the dashboard, which they enable you to do, and now showing you the repository where we've actually kept all these things, and we've also brought in data from a whole series of other places. The primary sort of data set of interest was the vaccination, and in fact that also incorporates cases and testing rates by MSOA, so by the MSOA sort of region size, and that enables us to sort of then start to compare between those between the background demographic data from the dashboard and the actual COVID related behaviours, and because we could. We also incorporated some information about vaccination sites and tried to tie those to locations, and that was particularly linked into the fact that Tom Forth from Open Innovations had just published a bunch of travel times by MSOA. So we were interested in whether there was an accessibility angle on that. So, is the fact that this particular area does it have low vaccination rates because it's really difficult to get to vaccination centres? So a whole series of things that we thought could be pulled together. I'll share the links to all of these repos so you can sort of dig into them. The other thing to say is these are mostly automated. So most of this stuff is just automatically downloaded so that we keep these visualizations up to date without any manual intervention. That was quite important for us because we don't want to make an enormous sort of maintenance job, and of course this data is still relatively fast moving. So what we produced was this visualization. I'll just make my browser window slightly wider, which hopefully will scale properly for you. We originally started with just a single view. This is a hex map derived from the House of Commons view hex map tile library. But so effectively this is West Yorkshire, South, East Riding around Hull, and North Yorks, and each of these is an MSOA, and you can see here I've got the first dose and the second dose vaccines, and you can select from all of the different bits of demographic data or testing rates or cases, so you can do a quick visual comparison between these regions and see if one hotspot ties up with another one. So there's a deprivation here. Does that tie up with limited amount of first dose? And because that's not necessarily obvious precisely, we've also got a correlation plot that demonstrates that. A couple of interesting ones. So this is the first dose by IMD score. So you've got sort of regions here where there's a higher IMD score, and that tallies with lower first dose rates. And again, that becomes quite visible on the correlation plot, and they're all sort of linked together. And then likewise, we've got another one, which is first dose via second dose. You'd expect that to be a nice tight correlation, which indeed it is. And there's the other thing is these outliers become very obvious when you've got them plotted in there. So there's a real question that I've got immediately, which is what's going on in Hare Hills. So we were sort of thinking about how this might work. This was effectively done within the course of a day, although there were a few sort of features that had made their way in after the fact because we noticed it was sort of useful. And in true Open Innovation style, we've written all of that stuff up, so you can actually read through and find out what we did and various sources of data and link through to the repos. So that was sort of end of July, and then at that point we handed it over to Magpie and said, "Here you go, we've built something." Tom, I'm really interested to find out what you did with it. We've not really spoken at great length about this. So how was this used, and what sort of difference did it make to you?
Yeah, so it was used really as the catalyst, I suppose, in terms of the conversations we started to have with every local authority in the region. So the way we've organised this, obviously with a big region to look after, is that we've got individual working groups with every single local authority. We're meeting every fortnight to discuss at LSOA level variations within the data, where the hotspots are, what the particular challenges are. And what we've been able to do is build a map of what's needed in the 10 least vaccinated LSOAs in every single local authority in the region, using this data and building on it with colleagues from across the system. But we've also tried to do, and I'll get on to this kind of issue of trust in a second, is build out a campaign. It's called covidexplained.com. It actually went live on Monday, so this is perfect timing, so that when people are seeing COVID communications in these communities, they know that it's actually something that's acting across Yorkshire and the Humber, isn't just being targeted at their specific community. There's a real feeling that if we went into some of these communities and just said, we're doing this for you, we're coming in, it's an intervention top down, it wouldn't work. So what we've been able to do is actually using the data, go into the communities, find real people's stories, and actually kind of really understand what's going on in people's lives. So to kind of bring that to life a little bit, we've seen, Giles, in some of those graphics you just presented there about IMD being a really kind of key factor within this. You dig down into that, and actually what we're looking at here is a series of different things. So one of the things here is around kind of precarious job contracts. So this idea that if you test positive for COVID, and then you have to self-isolate, well, you're not going to be able to bring money into the house, you're not going to be able to put food on the table, you're not going to be able to pay your heating bill. And that's a particular concern for people as we go into winter. It's not necessarily about people getting sick from COVID, it's about the inability to do other things that are important, make money. So particularly people on kind of 0 hours contracts and things like that. You've also got concentrations of people who don't trust official advice within the UK, so particularly from the government. So we've very deliberately kind of labelled this campaign, or we delabelled it, so it doesn't feature a local authority brand, it doesn't feature the NHS brand, it doesn't feature the UK government kind of marks in any shape or form. Because what you're seeing here is a lot of communities who actually don't trust the media over here, they don't trust government communications over here. They get their information from home, wherever that might be. So particularly when we're looking at Eastern European populations, their governments domestically and their media outlets have been very, very, in some instances, I guess, suspicious of COVID as a thing. So therefore, they think, okay, well, I don't necessarily need to do this. I don't trust the advice I'm getting from UK government to get vaccinated, self-isolate, and all these kind of things. And these things tend to layer up, as you find with all of this, all of this work.
So really, this is giving you kind of, the little clues that you can go in and then have that discussion with the people that know the areas much better, whether that be local community, whether it be the local authority, the health boards, and the like. So
yeah, exactly that. And then what we're doing through the creative team at Magpie is then creating materials, resources, written, featuring people from those communities. So it's the voice of those communities. It's a community up approach rather than a top down communication, that there are enough top down communications around COVID going on. So people see people that look like them, they hear their real stories through the campaign. And that's been a great way of actually kind of being able to kind of get messages out on WhatsApp groups, in community centres, all these things, where they're needed the most.
Really great. Thank you. Thanks for that. I think that's it from us. I don't think we've got more to say. As I say, I'll drop the links into the chat, and they'll be available on the event page on Open Data Saves Lives. I'll stop sharing my screen now. Hang on, that's the wrong one.
Thanks, Charles. Really interesting.
Thank you.
Nick makes a good summary comment in the chat about the difference between quantitative data and qualitative data, which I think and I'm looking at you, Giles, and Paul and myself, are kind of a bit too far sometimes down the quant side, just because that's the bit we're kind of interested. I think these groups are really helpful because they make us blend that a bit more. And the NHS, rightly or wrongly, have kind of got a model which I think is quite helpful because it's easy to remember because they're eyes, and they talk about sort of infrastructure, intelligence, and then intervention. they're now talking about incentives, and what that means is, you know, potentially changing funding between different organisations. So, you know, taking money out of the acute sector and putting it into mental health, for example. I'm kind of interested, Tom, just to come back on the end of that line of evaluation. So you've got you've got some infrastructure there, you've got some quantitative data, which Charles has helped with, got some qualitative people's voices. You go out and do an intervention. How do you tend to evaluate that? Because people usually forget or don't want to because it's really difficult.
Yeah, no.
Tell me a bit about evaluation, then we'll just come to you, Paul, if that's all right.
Yeah, so two ways we're doing that. One is we're doing it ourselves through Magpie, which is more of the kind of the iterative optimization of the campaign, for want of a better expression. Okay. So we're doing pre-evaluation and post-evaluation. So we've chosen 2 pilot areas. One in Hare Hills in Leeds. Interesting, Giles, you kind of picked that one out from the data. Well, the data probably helped inform the pilot, actually. And then one in East Marsh in Grimsby. And we've piloted the approach there. We've gone in and we've done activity with people talking about how they feel about the vaccination, how they feel about self-isolation and testing, and their propensity to access it at that moment in time. Then we deliver the campaign, and then we go back in and we ask the same questions again and look at the shift in terms of their propensity or reported likelihood of doing these things. So that helps us kind of, I guess, optimize the campaign. The more rigorous evaluation, I guess, the third-party evaluation is actually being done by NatSen. So because the money's coming from Home Office for this, there's a third-party evaluation partner who is independently evaluating the impact of the work across the region. That's happening in February, March.
Really interesting. Okay, we're 22. Paul, I know you wanted to say a few words about some of the other themes that we're doing, particularly around data ethics and events that we might run next year. So I hand to you.
Okay, can people hear me?
Yep.
And just a final point on that work that we did. Something that you will hear when you hear me talk about, there's it's about pace and being able to do things quickly and iteratively. The reason we were able to stand that tool up in a day and a bit was because we'd already been working with a lot of this data already, but we'd published all of our tools openly. So a lot of that work builds on the dashboards because we've been working with the data, we published everything openly. It was easy for us to use as well as other people. And that allows us to work at pace and answer a question relatively quickly. And I think if anyone's worked in health and someone has said, oh, could you put up a tool in less than 2 days? They'd have just said, you're having a laugh, aren't you? And I think one of the things we're going to be talking about next year is actually how does this group and Open Data Saves Lives and its partners and its sponsors inject pace into the health sector? Because from our work alongside it, I think we need to maintain the momentum that COVID has given us and the permission that it's given a lot of people to say, I don't need to write up a report. I don't need to make a proposal or do an ITT. We know we can do this. The data's already been published. Let's find the work to fund some teams to do that. So yeah, that's I'll stop ranting about pace and delivery and open and how we do that. What I'd like to do now is just introduce a topic of work. So alongside mental health, which is going to be a consistent piece of work for Open Data Saves Lives from now on, and it allows us to do that. I just wanted to talk about data ethics, and I'll share my screen. If you can see that, if people can let me know. Yeah, we can see that. So it's something that Open Innovations has been working on, and this is the page where last year we observed what was happening in the data ethics space, and when we absolutely want to maintain the high level of focus that's been completed on data ethics. However, what we were seeing was there was a lots of talk and little doing in this space. And we also saw in the same way that data governance, that it was being used as a thing to do rather than the focus of the work itself. And so we started a project at Open Innovations to start looking at data ethics. And We've got our view. We've done a check-in. We've started interviewing interesting people. So Sam Gilbert is a really interesting, he's written a great book about good data and how it can be actioned. Here we go. We've written up that interview. We've linked to his document. So we're trying to, in the same way Open Data Saves Lives wants to do that, we're trying to build some assets that we can all look at and refer to whenever people start mentioning data ethics, and we should stop and consider it rather than just being a piece of hygiene that happens with every project. So from 2022, this is going to be part of, we're going to transition some of this work into health. But obviously in health, we already do this. Most health professionals have taken somewhere in their contract, or if you're a medical profession, you've already said this. And I just move this over here. And stop sharing, and then pick share another screen, because if you've been listening to the Reef lectures on Radio 4, I just recommend everyone to start listening to Stuart Russell's work on this. So I'll share this now. But I recommend everyone to listen to Stuart Russell's Living with Artificial Intelligence. And one of the key points he makes, especially around ethics, is that a lot of this work has already been done. So in terms of the philosophical aspects of it, the economic aspects for it, and many parts of the social sciences have already done a lot of this work. So we don't need to redo all that. We don't need to open that research, but we just need to find some people who've done all the work for many, many years, ask them their opinion, and they will tell us. And that allows us then to get on with the technology, along with the data, along with the services that we build, and not rebuild or open up more aspects of research that stops us getting to the doing phase of projects. So that's something I'd like to just ask everyone to have a look at. Look at the LDI Leads Open Innovations work that we've done previously. Have a listen to Stuart Russell's Reef lecture, but then also maybe join in. So we're signposting this for next year, where we're going to start through Open Data Saves Lives a sharing good practice. And you'll see at the bottom of the Open Innovations page some tools, some examples of things that people have already done, like Open Data Manchester's statement on good data use. And just join in with that. You don't need to redo or remake that work. Join in with people already working, which will save you loads of time. And so it means you can get to the projects and deliver them in a useful way without stalling, and then removing pace and momentum from your projects. So that's all I wanted to say, Mark.
Yeah, no, that's really helpful. And the spirit of this is that people will share. So when we've had to convince people of a difficult IG discussion, we want to share the paperwork that we've done around that, because it's quite helpful the next time it happens. So out of this collaboration, the work around domestic abuse, we're now helping set up in another part of the country. So we've done it in Kent, we're now talking about doing it in Warwickshire. It would be amazing if we had that all around the country. It's a really, really simple KPI, but there's a lot of collateral that comes with that, which where we're able to, we're very happy to share. This is the legal argument, this is the ethical moral argument, this is the paper that describes those, and then all of the technical resources that is getting stood up as well. So it's a kind of, we want to highlight people who've done amazing things, but we also want 20 people to find it slightly easy to do because they kind of went first. So mental health will be a kind of thread through a lot of what we're doing. I'm interested, and I've been going on about it in the chat, about inequalities and unwarranted variation. So, challenging us to go beyond IMD, beyond black and white, beyond age groups, into more subtle data that, Tom, you would clearly have had to understand in what you were doing, talking to, community leaders of a specific ethnicity in a particular setting that was credible. We need to get the data to kind of catch up to help with that. So I think inequalities is a theme for us, and then the work that we're doing around data ethics. So to some extent, we're a kind of lobby agitating group. We believe there is some merit in linking data together, full stop sort of thing. be very careful on the IG, be very careful on the IT security, work within trusted research environments if you've got re-identifiable data, and so on. But step forward and try and, you know, use data for good. So
just one final point there. People ask us about, oh, we want to write our statement, we want to write our strategy. So the best people we know on this are Open Data Manchester. They've done a declaration of responsible and intelligent data practice. They've spent a load of work doing it. They published it openly. And I think part of our job is to share that good work with each other, so that, and it may be that we create some work for people who are already working on it, who we know we can trust already. And I share this all the time with people around the declaration of responsible data practice, because it's the best one we know, and we just signed up to it. So we can get Julian maybe to come and talk to us next year about this from Manchester. He's a friend of, and he will join in. And I think if we can find many travellers who are going in the right direction and make sure that we support each other in that way, and the best people, you know, it's trying to get the best people playing at the right time, and we don't need to all do everything in for every project. So that's me finished, Mark.
Okay, we always said we'd try and finish about this time each time, just to give you a little bit of time back. There's lots in the chat. We will write all this up. We will publish all of the sessions, the slides, the links, all of it. So it's a set of resources. Please use it, please share it, and we'll be back in touch with the programme for next year. Have an amazing Christmas, everyone, and good luck for next year. See you all soon.
Thanks, everyone.